welcome to the APAPP podcast. I'm Sarah Tomaszewski. I'm a pulmonary nurse practitioner at Prisma Health in Greenville, South Carolina. I run a nationally accredited pulmonary APP fellowship, and I am a proud board member of APAPP. And I'm very excited to welcome our guest on our podcast today, Dr. Kip Covington. He is a nationally recognized leader in dental sleep medicine and TMJ therapy. He's a founder of two referral-based specialty practices, South Carolina Dental Sleep and TMJ, and Carolina TMJ and Sleep Solutions. They focus exclusively on helping patients find relief from sleep-disordered breathing, cranial facial dysfunction, and chronic facial pain. With nearly 2 decades of clinical experience and a board certification from the American Board of Dental Sleep Medicine, he is known for blending airway-focused philosophies and practical patient-centered care. His practices are built on the belief that patients deserve both structural solutions and effective symptom management, whether through oral appliance therapy, interdisciplinary treatment, or regenerative modalities. There we go. I got it. So welcome, Dr. Covington.
I am happy to be here. Thanks for having me.
And so I kind of wanted to start this podcast today, if you could just kind of speak how you got into sleep medicine as a dentist and kind of what that looked like.
Frankly, it was by accident or fate. No, as a dentist, when I got into this wasn't really taught about that often. I remember through a small period of time, I had several patients asking me to help with their snoring. And I remember thinking, why are you asking your dentist? And so that went on for a little while, and I was just curious. And because this isn't something you get any training or knowledge on in dental school. And I finally found a course that wasn't being taught by a company selling something, because that's a big thing I was looking out for. And I went and sat through a 3-hour lecture about sleep and dentistry and how bruxism and how these things can be correlated. And I was sitting with my dental partner at the time. And I remember at the end of this lecture looking at her going, that was the most fascinating 3 hours I think I've ever sat through in dental continuing education. And she looked at me and said, it was okay. Yeah. I couldn't believe that we did not see eye to eye on what we were listening to. But from that day on, I looked at dentistry totally different. Things that we would see as a dentist, anywhere from like tooth wear to cracked teeth to things and associating how somebody may or may not breathe well. It was like a light bulb went off. And then for the next 10 or 15 years, I've just dove into learning more. And I think sleep's so fascinating right now. It's finally getting some credibility in the medical world that something we do a third of our life, that it should be valued. But yeah, so whether it was fate or accident, now it changed my career. I no longer do general dentistry, and now I try to teach more dentists to do what I think can be life-saving treatments.
Absolutely. Absolutely. So I wanted to focus today's podcast a lot about oral appliances because you are a wealth of knowledge about them and how they work. And so I was hoping that you could just speak to kind of what they are and how they work. We'll start kind of general, and then we'll get into the weeds of it.
So I would imagine most of this audience is probably, correct me if I'm wrong, very familiar with CPAP therapy, right?
Yes. So you're speaking to a very large group of pulmonary and sleep APPs, so PAs and NPs that do a lot of sleep medicine, but may not know as much about oral appliances.
It's interesting. A friend of mine, John Remmers, I think I've asked you if you knew him. John Remmers was a pulmonary researcher and hung out with Christian Guilleminault and this small group of people who discovered sleep apnea years and years ago as being a pressure problem. And John, I remember him telling me the story one night at dinner about him helping come up with the idea of CPAP therapy. And it was basically the story of him seeing this pressure issue and thinking, well, a vacuum cleaner has pressure, let's reverse the vacuum cleaner. And he's telling the story. I'm like, there's no way this can be a true story. And turns out I think it was true.
Yeah.
And Dr. Remmers just passed away recently, but Dr. Remmers then carried on that researcher mentality to saying, well, how else can we stabilize the airway? And anyone on this audience knows jaw thrust will typically open the airway, whether we're doing intubation um, or CPR or whatnot. So it was in the 80s and 90s that oral appliances first came around, and they were primarily being used at that time for snoring modalities. And it was just bring the tongue and the jaw forward, and lo and behold, you'd open the airway. So it wasn't really rocket science. And I think you've heard me say is what we're attempting to do, or in my simple mindset, is if we can bring the mandible or the lower jaw into a position, ideally where it would have been if we had room for wisdom teeth and big broad jaws like we were designed to, generally speaking, you open the airway. So probably a lot of this audience is familiar with Inspire now because that's been, marketed so well. Inspire is pushing the tongue forward. CPAP's putting air pressure behind the tongue or into the oropharynx or the velopharynx to keep that pressure gradient open. Oral appliances are bringing the mandible forward to open the airway. So the goal of all these things are similar, right? Is keep the airway open. And I think where we miss a lot of that is we keep the airway open in order to have somebody breathe better, but also in order to have somebody sleep better. So a lot of my patients come to us, and I have an interesting vantage point because for years to get to my office, you had to fail CPAP therapy. So I remember thinking for a couple of years, does anybody tolerate CPAP therapy just because you're jaded on who comes to see you? But you constantly have the patient saying, well, my AHI is shown to be improved, but why do I not feel any better, right? So whereas we see other interesting things happen with oral appliances, you'll have patients coming back saying, I feel so much better. And then a follow-up study may show that the AHI is not as decreased as much. And so then it's like I've dealt with this for a decade, is like, what do we do with these scenarios? But simply put, oral appliance therapy is trying to stent the airway open so that you reduce, whether you want to call it peak rate or collapsibility of the airway. So that was a long answer to your short question.
No, that was great. That was great. And so are there multiple different types of oral appliances, or when I'm talking to my patients, it's like, go see Dr. Covington. He has got one device to put
I
in.
think
Like
currently there are about 200 different FDA approved oral appliances. So then you're like, what the heck do we do with this? So I don't think that most people realize a custom-made oral appliance is one of the most custom medical devices on the planet. Now that we're just starting to get into 3D printing, knee replacements and things like that, it's starting to get that way. But in the dental world, no two devices will ever fit the same, right? So we talked about engineers before you hopped on. It's like oral devices are an engineering nightmare because they can't make two the same. Everybody's teeth are different.
Right.
But so in my practice, I use about probably 5 or 10 of these different devices. And the reason I have to use more than one type is because everybody has more than one shape. So if somebody has short teeth, there's certain devices we can use. If somebody has claustrophobia, there's certain devices I wouldn't use. If somebody has missing teeth, there's certain devices I wouldn't use. But I tell every patient, I look for 3 simple things in an oral appliance. I look for its comfort, or it's comfortable, because if it's not, they're not going to use it. I look that it's effective, and then I look that it's durable. So when I got into this a long time ago, we were making these kind of barbaric dental devices no one wanted to wear. They would break, they would fall apart. Medicare would only cover them every 5 years, and they wouldn't last 5 years. And then you're stuck in this weird window. And we can talk about insurance and stuff, but yeah. So I teach dentists to get comfortable using several different families of devices. Back when we used to do a lot of in-lab titrations, I had my favorite style that a respiratory therapist could adjust really easily. That's kind of gone away a little bit in our area, at least. So again, there are a lot of different types, and every couple of years something new comes out. But it's really technology's really just moved into making the materials better. So I tell most of our patients now, the device I make should last a decade, and by the time they need to replace it, it's probably because we have something better.
And so by picking a device, you take a lot about their history and basically your physical exam.
One of the common questions, which you'll probably get to, is like, what are the side effects of these things? So I have a unique philosophy because I treat half my practice is TMJ focused. So one of my mentors always is big on, he teaches around the world, and he says dental devices, oral appliances don't cause TMJ issues. People who don't know what they're doing with them cause TMJ issues. Um, so the common side effects that I used to teach on for oral appliances were you could accidentally move teeth around. That's not so much of an issue at all anymore because these things are 3D printed or 3D milled. Now, the over-the-counter devices, if a patient goes out and has one that is a boil and bite like they would make a sports guard, it's going to move teeth.
Right.
Because you're holding the jaw forward with the teeth, and there's forces there. Another interesting conversation is I think Inspire we're going to see after a while moves teeth. And your world probably doesn't know that a lot of CPAP masks will move teeth. So anything that puts forces on teeth are going to act like braces. So if you have somebody in a full mask, or even some of the nasal pillows, and you put enough pressure in certain areas, teeth may shift. But that doesn't happen near as much with these newer, nicer devices. TMJ issues, I treat a lot of TMJ issues with oral appliances. So we still have embedded in a lot of insurance policies that you can't use an oral appliance for somebody that has TMJ issues. That really means whoever wrote that policy didn't understand anatomy. But the biggest issue we run into, and it perplexes me, doing this 10 or 15 years, is some patients, as you wear a device and you hold your jaw slightly forward all night, every night, some patients will have difficulty getting their bite back to normal in the mornings. I'm convinced it's our patients who still brux or clench on the device, or if the device isn't adjusted well. But what we do, and every dentist should be trained to do this, is we make something for our patients to try in the morning for two reasons. One, to help reset their bite, to just remind their musculature where it should be. And two, to show us if there's any problems happening so that we can reverse those.
Right. It's better to act early on that if
I
their
tell
bite's
patients,
getting
if a
off.
patient comes to me and they've had a bite change, and within 6 months, I can usually get it back. If a patient runs off for 10 years and comes
Right.
back and they're like, hey, my bite's been off for 7 years, it's going to be hard. And it's interesting because a lot of times patients aren't aware of it. Their dentist may bring it up, or so we teach our patients to look out for these things so that we can prevent them.
You talked about moving teeth. I think that's something that a patient has brought up to me. A lot of people wear retainers or night guards for grinding their teeth, and the appliance kind of replaces that, right? It serves as their retainer from when they had braces 15 years ago, and for their sleep appliance. Is that correct?
This would take the place of a retainer, particularly the way they're made now. Now I have a unique opinion on night guards. Dentists, we sort of give out night guards like Oprah gives out cars. And the concept is if you're clenching your teeth at night, we should be protecting your teeth, and we should use these pieces of plastic to reduce the clenching that happens. The problem with that is I don't know that we still quite understand why people clench their teeth. When I think I told you earlier, for me to get boarded through the academy, the way we used to have to do it is I had to spend so many hours in a sleep lab, and I used to watch, and I would hang out with the respiratory therapists, and they would point out certain things, particularly when people are going through different sleep stages. And when I would see bruxism, I would look at it as a totally different, from a different vantage point than the respiratory therapist would. They would say, hey, look at the muscular activity, they're getting into REM sleep, or they're coming out of REM sleep. And I'm like, yeah, and they're also destroying their teeth. So I learned a lot by doing that. And I wish that every dentist that got into this world had to do that. It's just not feasible anymore. But there is for sure a connection between sleep apnea or upper airway resistance syndrome and bruxism. So to me, if I'm going to put something in somebody's mouth to protect their teeth, I'd also like to protect their airway if at all possible.
Right. I agree. So when we're as APPs, when we're evaluating our sleep patients, like who are the ideal
Yeah, so
candidates for an oral
your
appliance?
perfect patient is somebody that has a set back lower jaw. And we can all see that, right? It's like, particularly you're in the southeast with me. So uh but if you can look at somebody and say, if their lower jaw came forward slightly, would their airway be better? That's the ideal dental patient for oral appliance therapy. The not ideal patient is somebody where their lower jaw is larger than the upper jaw. We call that a class 3 underbite. In those cases, bringing the lower jaw forward's probably not going to open the airway that much. Now, in my practice, I would still treat that patient if they're CPAP intolerant, because I know that something's better than nothing. Um, but those are patients that my eyes would be going to, if it's a young, healthy patient, would be like, would they want any? And we don't recommend this very often, but surgical treatment to move the upper jaw. Uh, because it's the soft palate that's usually the problem. So my research leads a lot of people to say one of the biggest risk factors for sleep apnea is the distance from your spine to your upper front teeth. So the further forward that is, the bigger the airway is going to be, right? Um, and we can't move the upper jaw with a dental device. Now, there is a really fascinating world out there. Harvard and Stanford and some other places are looking at orthodontics for looking at sleep apnea treatments. And I think we'll be having different conversations in a decade or so. But the other people that uh, aren't necessarily great candidates, super narrow dental arches, um, it's again, I would treat those. I kind of brag about the fact that I think I have a higher failure rate than most people in terms of oral appliance therapy. And I say that because I'll treat anybody who's CPAP intolerant. And again, if they're not an Inspire candidate and utilizing a modality to help get them better until they can get better, right? But no teeth. You and I have had that conversation. If that,
Yeah. I,
yeah,
I really want you to talk about teeth because I feel like, we're examining people's airways, we're looking at their mouth. Like, how do I, as an APP, decide if their teeth are good enough that they could have a appliance? Like,
I
what would
always
be
try
your
to make
advice?
life as easy on my referring providers as possible. So I think I've told you, give me 6 teeth on the bottom. That's all I need.
And so you don't need any teeth on the top,
I
or
don't
what
need
about
any
just
teeth
the
on the top.
one tooth?
Um, and the reason being is if somebody doesn't have top teeth, usually they have a nice upper fitting denture because there's a suction cup that comes on the top. On the bottom, you don't have that effect. So if somebody doesn't have enough teeth on the bottom, then the device isn't going to stay in. Uh, the other thing, and I talk about a lot with my patients, is they have to have a nose that works. Um, so there have been so many patients of mine that have been referred to me, and the very first thing I look at is they have complete nasal valve collapse and they have an obviously deviated septum. And I think getting an oral appliance in there is still going to help. But I tell them, I was like, we're not going to get this resolved until we can get your nose open. So I'm an ENT's best friend.
And so what about, we get lots of, when I first learned about oral appliances many years ago, I feel like there was a lot of misinformation about the quality of teeth and if you can have crowns and caps and you have to be worried about them cracking teeth. And so we get a lot of patients that have questions about that because they've spent a lot of money on their dental work. And so do we worry about these devices cracking, crowns and caps and implants and all that stuff? Because those are the questions we get.
Yeah, no, spin it the other way. If you're going to invest that much on your teeth, do something to protect them. Um, and these devices now, like when I tell you, like a computer makes these for the most part, not all of them, but the ones I use, they are robotically made. And I put in my prescription for these devices where there's a crown, where there's a veneer, where there's an implant, and it will offset that. I don't think people understand how nice these things are made now compared to what we were using back in the day. Um, but again, if a patient ended up needing crowns and it wasn't for decay, it was for fractured teeth, then I'm asking the next question. Why did they have so much force to break teeth. And then you start
Right.
asking patients about their sleep, and now you start figuring out, hey, the dentistry led us to a sleep apnea diagnosis. And then,
Right.
well, let's protect these teeth. So,
Uh, So there's no contraindication for crowns and caps and all the other implants in people's mouths.
no, and there's a big trend in dentistry now, whether it's a great thing or not, is if you have lots and lots of bad teeth, to take them all out and put implants in and put in screwed in dentures. I even make sleep appliances over those cases.
The implant. Okay. Well, that's super helpful. And that kind of gets me to my next topic of like, could you walk me through, like, if I'm trying to explain to a patient, okay, I want to refer you to get an oral appliance, what is that going to look like? So from the first office visit to where you feel like the device is optimized, like, how would you explain that to patients?
Yeah, so typically, again, my practice is a little bit unique because this is all we do. And hopefully there's somebody like me everywhere, and we'll talk about that in a little bit. But generally, we're coming in and we're doing a pretty thorough dental exam to make sure that they don't have, now, on the teeth, let's say somebody has periodontal disease that has mobile teeth. All right, that'd probably be one of the big contraindications. If somebody has loose teeth, uh, I would still treat somebody that has severe apnea because I care more about their heart than their teeth. But that's one of those things you have to be careful for. So,
Yep.
but that's what we're doing on an initial exam. Hey, do you have teeth? Do you have any pre-existing temporomandibular dysfunction? That's one of the things I look at because it helps me decide what type of device to use or not use. Are you anatomically a good candidate for this type of treatment? So those are things I look at in a quick 30-minute evaluation. If they are, we're taking a digital scan. We don't take goop impressions anymore.
No gagging people with the big pink goo anymore.
No, and what most people don't realize is sleep apnea. If somebody has sleep apnea, they generally have a heightened gag reflex because the gag reflex's purpose is to protect the airway. So I spent years taking big goop impressions on people who all had gag reflexes. So
People have a lot of vomit over the years.
So no, now we use a very fancy camera to scan the teeth and give us a 3D printed model. And typically, my average device takes about 2 to 3 weeks to get made now. And then patient comes back, we fit them for it. And these things fit so darn well that I tell people if I have to adjust them in my office for more than 3 minutes, I'm remaking it. And then in my practice, we do a lot of telemedicine because during the titration phase, CPAP, you guys set, well, if it's a traditional CPAP, the pressure was set in the PSG study, right? And then you're starting with efficacy and then working towards comfort. We do the opposite. We start with comfort and then we work towards efficacy. So the first week to 2 weeks, I tell a patient, all I care about is that you can sleep through the night with this and it's not hurting a tooth or your jaw or your muscles or anything. Let's just make sure it's comfortable. And then whatever devices we're using, then we start titrating. And titrating is, generally speaking, is bringing the jaw slightly forward by millimeter increments. And we're doing small increments. And then I typically will spend 1 to 2 visits just making sure somebody's comfortable and we titrate them based on the initial presentation. So in my office, if you're mild apnea, most of my titration is based on subjectiveness. Are you sleeping better? Whatever those initial symptoms are. If somebody has deep desaturations, as soon as I know that they're comfortable, then I'm measuring O2 sats.
And when you're titrating, what exactly does that mean?
Yeah. So in most devices, they are adjustable by changing, either turning a screw or changing a band or changing a tray. Every device is a little bit different, but what you're doing is you're setting the position of the lower jaw to where it can't fall back from. So if you're listening to this, most people can make a snoring sound, and as you bring your lower jaw slightly forward, that snoring sound will reduce. There's all kinds of fancy ways to measure that. I think I talked to you about this at one point. There used to be what was called a matrix system that was a dental device that you could hook up to the PSG study, and it would move all night every night. And it would gauge where does the jaw need to be in order to reduce the AHI. And then they made one that was hooked to an HST. and I'm the proud owner of one, and it is worthless because we're not a business because there wasn't much of a demand at the time. But it taught us so much because we used to think that you had to bring the jaw really far forward. A ton of our patients, we do not have to bring the jaw forward at all. We just have to keep it from falling back. So it changed how I treat people. Now I put somebody in a very comfortable position wherever their normal bite is, and then we will slowly titrate or adjust the device forward based on their symptoms.
Got it. Okay, that's awesome. And how long does that normally take?
Uh, tip-
What does that timeline look like?
yeah, typically you can do that within 2 or 3 weeks. Uh,
And then do you tend to order a repeat home sleep test? Or I know you talked about hypoxia. Do you just do an overnight oximetry, or do you just they're feeling better? That's good.
yeah, so everyone does that different, and it depends on the dentist geographics and who they're working with. My my perfect scenario, and I would love for this to happen, and maybe you can speak this into existence, would be for everybody once I had them subjectively feeling better, whatever initial symptoms led them to a sleep study, snoring down, comfortable, headaches, whatever it was, improved. They go back into the lab and do an in-lab titration. That
And
that's not real.
I don't know about that.
In some places, that's actually what's done. In
Yeah.
some places, I would send them back and have whoever the referring provider was order a 3-night HST and do a serial titration. Something exciting that's coming out is 2 or 3 of the main oral appliance companies are almost there to embed sensors into the device. And the sensors are either going to measure AHI, ODI, some of them might be sleep staging, and then you guys might be doing the follow-up reading just like you would see a CPAP report.
Wow.
So that may completely change how we're doing things.
Right.
So I use all kinds of things in my practice. If a patient owns an Oura Ring or a Whoop or a Garmin, I may use some of their data that they have because I like the longitudinal data.
Right.
I use a sleep image ring. Back when I got into it, it wasn't diagnostic, and that's technology's changed. And so I think it depends on one, as a dentist, what state they're in, because there's certain things dentists can do in certain states. Like in Georgia, a dentist can't use an oximetry unit, which I think is wild.
Huh.
So then it's on to the provider to do all the testing. The last thing I want to do is send a patient back to you and they're not titrated well, and you have to send them back to me to do further titration. So that's not a perfect world yet, and it just depends on where you are.
Got it. Got it. And then the next question we get from our patients is how much is this going to cost and is my insurance going to pay for it? So could you speak a little bit about like billing for these devices and what we can, and our patients can anticipate having to pay to get one?
Yeah, that also is going to completely depend on where they are.
Right.
So the biggest hurdle for dentists to get into this world, and I don't think people realize this, is medical insurance. It took me half a decade to get listed as a DME provider so that I can provide this for patients. So what you'll have is a lot of dentists, and they get a bad rap. These things aren't cheap to make, what the dentist pays to have these things made. So you can use very cheap devices. I'm not putting a patient in a cheap device because then I'm liable for all the problems that happens. But once a dentist figures out that there's this need, most dentists will start working with billing companies. My average patient in December pays nothing.
It's deductible.
Yeah, they've met their deductible.
And so they can get billed through medical insurance. I think that's a big, people aren't aware of that. They think it all has to do with dental insurance.
Yeah,
But
none of this
because
fall under dental. So we have one code. It's E0486. So when dentists realize that, and it's a headache, and if anyone listening has a dentist they want to work with, they want to contact me to figure out how to get into this world. I have friends that do consulting for dentists to learn to do medical insurance. That's a huge headache.
Yeah.
But it's worth it because it allows us to treat more people. When I got into this, all I could do was treat rich people because insurance didn't even think we existed. So like in my office, we're in network with every insurance other than United Healthcare. We're in network with every insurance we can do, and some of that was literally acts of Congress. Certain states, it's still hard.
And is there certain things that us as the provider need to have documented in our note to help get that covered?
Yeah. So, generally speaking, and I always teach people Medicare guidelines because they're the strictest.
Mhm.
So with Medicare, if somebody has severe sleep apnea, they've had to attempt CPAP and or have a reason not to. So if they have claustrophobia, it just needs to be really well documented. Um, a lot of insurances, if it's mild apnea, they have to have some type of comorbidity associated with it. I think these are things y'all are used to seeing, but it's just not brought up all the time. Uh,
Right,
one that's kind of gray is, when is the last sleep study needed?
right.
And that is so plan specific. It drives my billing team crazy. So Medicare is black and white on that. They say that it's studies needed within the last year,
Mhm.
although they don't enforce that. So the problem with Medicare is that you guys don't have to deal with this that often, but they like to come back later and say, "Hey, you did something wrong. Well, pay us back."
Oh, gotcha, gotcha. So, a general rule of thumb, if they've had a sleep study in the past year, you're probably very good. If it's been longer, it could be hit or miss, but they will take home sleep tests as well, though,
Absolutely.
because we have a lot of insurances that deny in-lab tests. We only get a home sleep test, so it's good to know that that could be adequate to get a oral appliance approved.
Well, I just had a recent plan out of nowhere, and I helped them write their policy years ago that decided to start denying oral appliance therapy because the patient did not have an in-lab study. And
Yeah,
I said, if you want me to send all these patients back for in-lab studies, I'll be happy to let you pay for it.
right.
But yet they won't cover the in-lab study until the HST's done. So yeah, insurance, you know, y'all, it's the worst thing we deal with. But yes, oral appliances should be covered under, generally speaking, most major insurance companies.
Good, good. I think that's super helpful. And then I kind of wanted to talk about the collaborative relationship between, sleep providers, APPs, and physicians, and sleep dentists. And like, what does a really good working relationship look like? Like, what do you hope as a sleep dentist that the back and forth looks like?
What ours looks like. That um, I think I was in a unique position that I did a residency in a hospital. So I used to sit on a head and neck tumor board. Dentists and you guys, we have different languages. And I teach dentists all the time. You have to learn other people's language, like soap notes, for instance. That's not a dental thing. So if a dentist is looking to work with you, I think we have to change some of our vernacular. Patients do better when we communicate. So it's hard for a dentist to, like, I have access to Epic. That's a unique thing. Um,
Mhm.
so there has to be communication back and forth, and the better the communication is, the better the patient care is. Um, so I think if it's somebody in your audience that is looking for this, there are people. Sometimes there's people out there looking for each other, and they don't know where to find them. Uh,
Right.
and the It took me, I was at the AASM meeting in Baltimore one year, and I took out one of the pulmonologists in your practice. And I was like, why did I have to come to dinner with you in Baltimore for us to realize we existed?
And we really help each other out.
Yeah. So, and then dentists are looking for patients. Like, now every dentist is being taught to screen for sleep apnea.
Right.
And then
Absolutely.
what do they do with these patients? So it's a
Right.
perfectly symbiotic relationship.
Right. So from an APP perspective, making sure you write good notes, you document what's been tried and failed, make sure that they've had testing recently. And then I think from a dentist perspective as an APP, what I like to see is like, I like when I get feedback back from the dentist, like, hey, we set your patient up. Like, we may need to repeat testing. Like it, like you said, just having open communication is super important. So you know what's going on with your patient and if you should like, okay, well now we gotta look for something else to treat them with because this wasn't successful.
Yeah, I try to always ask a new referring provider what communication they want. Like, you guys are used to being able to go into Epic and seeing every chart note. That's difficult for us to put into your system. So I teach dentists they should let the referring doc know the patient came, were they a candidate, are they going into treatment, and then when they're ready for whatever type of follow-up testing. Um, and or if there's any hiccups along the way. And I think that's generally at least what the referring docs should know, right? But if you want, I have one referring physician who wants to know every conversation I have with a patient. And I'm like, by all means, have it.
Yeah.
So
Well, somewhere in the middle, maybe.
yeah,
And then I kind of wanted to talk with you a little bit because, we love knowing more about like cutting edge things, what we should look out for in the future. I loved hearing about like the monitoring uh stuff that's going to go in an oral appliance. Like what can we look forward to in the future in terms of oral appliance therapy and things that we should be on the lookout for?
what to look forward to and what to look out for.
Well, maybe a little bit of both.
Yeah. So
We can be
I think I think the communication, back to the communication, I think the communication is going to totally change when we have these sensors that I'm talking about. I don't think it'll change the way I treat anybody, but I think it'll gain dentists the credibility because we're seeing that live reporting that you guys are used to seeing from a cloud-based PAP report. I think that's a big deal, and you have a lot of these bigger companies really investing into that. Still some unknowns about is that a billable treatment for you guys or whatnot? I think that's a big deal. I think you're finally starting to get like one of my favorite devices or the companies has spent a lot of time re-engineering their device to really work on getting patients' lips closed. And by opening or closing the lips, there's good research to show you'll open the oropharynx. That's exciting.
mouth taping could be a whole nother podcast episode.
Yeah, which is well, that's yeah,
Let's be happy on it.
I think combination therapy is something that is not used near like it should be. And I think that's where we can make the biggest impacts. And when I say combination therapy, I mean oral appliances with PAP therapy. I mean oral appliances with Inspire. I mean Inspire with a nasal PAP. We're still so isolated that if a patient fails PAP, they automatically get sent somewhere else. And if they fail that, they get somewhere else. I ask every PAP intolerant patient, what was it they didn't like about it? And if they said the pressure was too high, then immediately I know if I put an oral appliance in their mouth, I can probably dramatically reduce the pressure, move them to nasal PAP. And I've got lots of combo Inspire cases where the Inspire with the settings that had to be set up to control the apnea kept the patient awake. And once you put the oral appliance in and they were able to reduce the Inspire voltage or whatever you want to call it, patient automatically started getting more REM sleep and deep sleep. So I think that's something that's exciting that I think when we start working better together, it's like, hey, whatever combination or modality of treatment combined to get the patient the best outcome. And then I'm somewhat excited and a little nervous about what does it look like with combining our treatments with GLP-1s and all these different modalities and all the pharmaceuticals that are coming out to treat sleep apnea. I think it's a moving world that we're in.
Yeah, we're here for it. We love having more options to treat this disease. So, any key takeaways for the listeners today of kind of any advice for us as APPs, working in sleep medicine and seeing these patients from a sleep dentist perspective?
Yeah, I think one, there are dentists looking for you to work with. That's another thing that's really awkward for dentists to do is to go to a medical provider and raise their hand and say, I'm here to help. Not awkward for me. It's not my personality is totally fine with that. But for most dentists, I have partners, they will not step foot in your office. They are so intimidated to do so.
It's scary, I promise.
I don't know. I don't know what it is. But so if your audience was looking for dentists to work with, I think if you go to the American Academy of Dental Sleep Medicine. So if you just Google American Academy of Dental Sleep Medicine, there is a find a provider.
Okay.
And they're all over the place now. I always say, look for the boarded docs. Cause they have a star by their name or a check or something. But if not, and if somebody has a friend that's a dentist that wants to get into this world, I love doing that stuff. So they can reach out to me. But like I said, it's a practice builder for both. Like, and you're in a hospital system that's has a ton of volume. Not everybody's like that, right? So there's people out in private practice that are looking for patients. The dentists have them. And so if we work together, again, the biggest issue is the vast majority of the patients are undiagnosed.
Right.
So
Right. And we can offer some interventions to help them out. I think that's super helpful to share. Because we have listeners from all over the country, and even there's listeners from over the world that listen to this podcast, and knowing what resources you have to find sleep dentists in your area, and then get more education on oral appliances for the treatment of sleep apnea.
Yeah, and then what to look out for. There's some companies in the dental world that throw out some claims that probably aren't warranted. So if you see companies claiming that their devices cure apnea, there's just some red flags, unfortunately, in every world. That some companies have gone out and marketed some things that probably may or may not hold a lot of validity to them. And we have some of that in our town. But like we talked about earlier, I think if there's an exciting time that's connecting the dental and medical bridge with some of the orthodontic, or call it orthopedic changes, particularly with kids, that you can make to try to grow somebody out of having an anatomical problem for sleep apnea. That's super exciting. And I can come back and talk for hours on that, because I think I think we will look at sleep apnea totally different in the next 10, 15 years because of some of the craniofacial changes you can make. And I think that's going to trickle into adults as well, or already is. It's just a little bit harder.
Awesome. Well, that's great. We actually have a lot of peds pulmonary APPs part of this group. So talk with your local orthodontics about your peds pulmonary patients.
Yeah. So let me throw out one thing that I read that was really fascinating. So with the pediatric population, tonsils and adenoids are shown to be about 60% effective in treating sleep apnea. You combine that with, we call it rapid palatal expansion, but upper expansion of the upper jaw. It's like 95% effective. And don't quote me on those numbers, but it's high. What hasn't been talked about that much is, what if you reversed it and you start with getting the upper jaw developed, the nasal complex developed, and get kids breathing well? A grade 3 tonsil will look different in a bigger airway.
Right.
So again, that's where the collaboration for sure has to start happening, is our kids and the growing, developing kids. But there's also some crazy claims out there coming from the dental world that, like, oh, we can treat all these things. And I don't think that always comes from a bad place. I think it comes from a hopeful place. But yeah. So.
Well, great. Anything else to add before we wrap up here?
Yeah, if anybody's looking to move, Greenville, South Carolina is always looking for good people.
Yes. Everyone's moving here. Well, I just wanted to thank you so much for joining us today on the APAPP podcast and sharing your knowledge and expertise and information. I think it's always exciting to have more options to treat our sleep patients. So thank you for your time. And I want to thank you all for listening to our APAPP podcast. Don't forget to subscribe. And if you're interested in joining the sleep committee, you can email info@pulmapp.com to join the sleep committee. So thank you so much.